How are you, my friend?
I'm good. How are you?
Everything is okay. So I think we can start, and I will introduce you at first. Добрый день, уважаемые коллеги. Разрешите начать сегодняшнюю школу онкологов, которая посвящена вопросам диагностики лечения лейкозов. И наш лектор – это Майкл Джей Мартин из West Cancer Center. Dear Michael, you can start your presentation.
Hi. Good morning, everyone, or I guess good afternoon. I'm going to actually do this in a fashion similar to how I gave a talk with when I was in Uzbekistan. And you liked the way I did that. So instead of doing slides, I'm going to do notes. Can you see my screen?
Not yet.
Let me see how to share my screen. Participants share screen. Can you see it now?
Yes.
Okay. So what I'm going to do is, since we're talking today about leukocytosis, I'm just going to go through the disease, the 4 major diseases for leukocytosis, how to work them up, and how we currently manage them in the US. Rather than just drilling you with 1,000 slides, we'll kind of go through it more free form. I can give you slides later if you would like them, but also this opens up if any one of you guys has any questions or if anything's unclear, let me know as we go through. Make sense? So we'll start off first with chronic myeloid leukemia. This is one of the 4 diseases we'll talk about. We'll also talk about CLL, we'll talk about AML, and we'll talk about ALL. These are the 4 most common causes of malignant or neoplastic leukocytosis. And again, that's supposed to be the topic for today is leukocytosis. So starting with CML, CML is a myeloproliferative disorder. It is caused by the acquisition of the Philadelphia chromosome, which is a translocation between chromosomes 9 and 22. This is necessary and sufficient for it to cause chronic myeloid leukemia. You do not need any abnormality other than the 922 translocation. And it's reciprocal, right? So whenever you have a 922 translocation, you also have the opposite translocation as well. So if you take, for example, if you take a mouse with a mouse model and you give it a lentiviral vector. This is the stuff that I used to do back when I was doing basic research. And you give a lentiviral vector to deliver the component of the 922 transcript to a mouse, you will actually give the mouse chronic myeloid leukemia, creating an almost perfect model for chronic myeloid leukemia with that one abnormality. With that one abnormality, you can start testing things, right? And that's how imatinib and the other tyrosine kinase inhibitors came out, right? So imatinib was the first TKI to come out, or tyrosine kinase inhibitor. And what it does is it's an ATP mimetic. So it goes into the pocket created by the Philadelphia chromosome or the 922 translocation, and it outcompetes ATP. And when it goes in, then it instead of stimulating it by giving it ATP, it shuts down the tyrosine kinases and stops intracellular signaling. The fact that the 922 is necessary and sufficient, that's all that you need to cause CML, is really probably one of the reasons why it's become a complete poster child for easily blocking it and for us figuring out how to treat it. This is interestingly in contradiction to another disease. Is this too small, or can you see it?
I think if you make it bigger, it will be better.
Yeah. Boy, that's painful. Should just let me make it much bigger. Okay. That's different than for within AML, there's a subdisease called acute promyelocytic leukemia, which is also defined by abnormality. It's defined by translocation 1517, right? Which I think everyone knows that for defining APL. The thing that's interesting though is if you take a translocation 1517 again in a mouse model, and you put just the 1517 into a mouse, you actually get nothing. You actually what you get is a myeloproliferative disorder, but it is not acute promyelocytic leukemia, which is one of the things, again, that's making it's so special for chronic myeloid leukemia that it can be caused just by one abnormality. And in order to actually cause acute promyelocytic leukemia in the mouse, you have to put in a lentiviral vector giving them both the 1517. Then you have to give another lentiviral vector giving them the reciprocal. So you also have to give them a translocation 1715. So switching the genes into opposite orders. And you have to make them haplo insufficient, which means you actually have to breed a mouse that it only has one copy of chromosome 15 and one copy of chromosome 17. So in order to cause acute promyelocytic leukemia, you actually need 4 different genomic events. You need the 1517, you need the 1715, and you need to knock out both 15 and 17. So there is no normal copy of PML or RARA. So it's a much more genetically complicated disease with APL, which is why there's no cute little tyrosine kinase inhibitors or anything else that can knock it out, as opposed to CML, where you just have a single abnormality causing all of the damage and all of the problem. It makes it lends itself very much to being able to be studied and be treated relatively easily. So this was originally studied in with chronic myeloid leukemia, actually backing up. So does that make sense about the genetics and how, even though we define them by saying that there's only a single translocation for both of them, APL is a dramatically more complicated disease because it actually has 4 genetic events instead of 1, again, lending CML to be treated much easier and to be unraveled much easier. So if we go back to when I was a fellow with CML, the way that we originally treated it was with sub-Q, ARSC, and interferon. Doing that, we would induce remissions in people and right around 40 to 50% of people, but everyone would die in about 3 to 5 years. So your life expectancy was 3 to 5 years. So you would refer everyone possible for an allo transplant. In the absence of allo transplant, everyone would die. Everyone would eventually switch from chronic myeloid leukemia. Then they'd go through the 3 phases, which, as we know, for chronic myeloid leukemia, you have chronic phase, you have accelerated phase, and you have blast phase. So eventually, when you're treated with just ARSC and interferon, you will switch through the phases. Again, accelerated phase being defined by having increased number of blasts and getting additional cytogenetic abnormalities, because the BCR-ABL, which is the Philadelphia chromosome right here, right? The BCR-ABL rearrangement leads to intrinsic genomic instability. So the longer it's present, the more genetic abnormalities will be acquired by the individual. So over that 3 to 5 years, they'll go from having a single genetic abnormality, which would be potentially targetable, to having complex cytogenetics where they'll have many different abnormalities, making it dramatically more difficult to treat. And then they will eventually succumb to the disease, switching into a blast phase where they're having over 20% circulating blasts or in the bone marrow. And that's an extremely resistant disease. Even when you can induce remissions, they're usually very, very short-lived. So the key is treating it and diagnosing it early. Fortunately, though, imatinib came out in what was called the ISIS trial, ironically, where it was randomized to people with a chronic phase 1 CML to either ARSC or to imatinib, and it showed a dramatic improvement in outcomes with imatinib. And the vast majority of these are sustained. Indeed, only around 5% of people that went into blast crisis on this imatinib study. So 95% of people had disease control with imatinib versus 30 to 40% with Ara-C and interferon. And the interferon and Ara-C eventually would fail, whereas imatinib does not necessarily fail. People can be on imatinib for 20 years and still be in have disease control for it. A couple quick words on diagnosis in CML. Clearly, you need to find the BCR-ABL transcript, and you need to check for this both by FISH and PCR, because remember, there is 1% of people who will only be FISH positive and will be PCR negative. So at diagnosis, you need both FISH and PCR to prove that you can then monitor them by PCRs, and you still need a bone marrow biopsy. So you still need a BMA, bone marrow aspiration, bone marrow biopsy, because that's the only way you can define the additional cytogenetic abnormalities to actually correctly phase somebody out, whether they're in chronic phase or accelerated phase. And that has differences for dosing of your tyrosine kinase inhibitor. There have been a bunch of other tyrosine kinase inhibitors that have come out. Things to notice about them is with the second generation tyrosine kinase inhibitors, which are nilotinib, dasatinib, and bosutinib. They're all, what they do is they decrease the chance of going into a blast crisis to 2.5% instead of 5%. So you have a decrease in chance of going into blast crisis. But other than that, all of their approvals are really just based on changing surrogate endpoints. There is actually no difference in overall survival for them. And there's a big move in the US to actually start moving away from using nilotinib, dasatinib, bosutinib in the first line, because they're dramatically more expensive. And really what they've been shown is they make you hit milestones like complete cytogenetic remission and molecular remission at different and better time points. And there is the belief that that will lead to long-term outcomes, but actually none of them have been shown to be superior to imatinib. So imatinib is a completely reasonable place to start. And each of these other drugs has its own unique side effects. For example, nilotinib has pancreatitis and elevated QTc. Dasatinib can cause this weird autoimmune complex of swelling and effusions. Bosutinib causes a whole bunch of diarrhea. Whereas imatinib causes basically periorbital edema and modest diarrhea and is dramatically better tolerated. So a lot of the times now in the US, we're going back from using the much more expensive drugs to actually starting with imatinib. And then if we're having side effects or if people aren't actually going into remission, that's when we talk about changing. The one difference for that is with ponatinib, which is the only traditional TKI that hits T315I. And T315I is a resistant mutation within the ABL pocket that renders imatinib, nilotinib, and dasatinib all not usable. So ponatinib does work in this situation. Its problem is it causes cardiovascular events. It can cause heart attacks, strokes, and I've actually seen it cause someone's leg to clot off and them to lose their entire leg, which is usually not what you're attempting to do. But these are the main drugs that you would use. So when you're looking for someone and diagnosing them with CML, they need to have the FISH, the PCR, the bone marrow aspiration to correctly phase them out. We would typically then be treating them with imatinib up front. If they are not responding to imatinib, then you would do mutational profiling looking for the T315I. If you see the T315I, then you need to switch over to ponatinib. And there are other newer agents such as homoharantinine, and there's a new BCR-ABL tyrosine kinase inhibitor that hits a different pocket, but all of these are brand new and still super, super expensive. How hard is it for you guys to get imatinib in Uzbekistan?
I think we do not have access to this drug.
So there is a website called Mark Cuban, cost plus pharmacy, where 1 month, and you can just Google that, 1 month of imatinib is $4.30. So you do have access to it. Anyone can get it. It's $4.30 a month. So before it went generic and it started being sold at other websites and everything, it used to cost 12,000 USD a month. Now it's literally $4.30 without insurance. So the majority of my patients don't even use insurance to get their imatinib. They pay what it would cost in the US to buy a glass of beer or a coffee to get their drug for a month. So it should be extremely treatable all around the world and very, very easy. If you guys have any problems and you have a patient with CML that you cannot for some reason get imatinib, even though you should be able to just buy it and get it shipped, you could get it shipped to me and I will ship it to you. It is really easy to get now. So this should be an extremely treatable disease everywhere in the world now because it should be dirt cheap to treat. And again, remember the alternative of it is of not treating it and catching it early is that you would need to take someone to an allogeneic stem cell transplant, which I do not believe you guys have available. And if you do have it available, it's going to be dramatically more expensive and they'll probably have to go to Russia to get it. So this is a very treatable disease. It's a disease that you can diagnose just with doing your bone marrow biopsies, and it is extremely cheap to treat. General follow-up for CML is once they have gone to hematologic complete remission, which essentially means that they have normalized their CBC, then you just follow them once every 3 months with a PCR if you can afford it. If not, you could do bone marrow biopsies until they went into a cytogenetic complete remission. And after they were in a cytogenetic complete remission, then you could just follow them with CBCs if cost was an issue. But here, just to show you this, because it is actually true, this is, you guys can still see my screen, right? You can still see my screen?
Yes.
So here is the Mark Cuban cost plus. So for providers, which because we're all doctors, so medication and imatinib. Oh, I'm sorry, it's $14 for 30. So if we switch it up to for 2 months supply at 400 milligrams, it's $75. So you're getting a savings of $19,314. So this should be extremely available and you should be able to get it.
I have checked the website now, so I also could find it in Tashkent. I'm sorry.
You can find it?
Yeah.
Yeah, and it should be
another name, but I could find.
Yeah, it should be very cheap. So that should be something that you should be able to do and use and treat. Any questions about CML?
I think you can continue.
All right, so we'll move on to CLL as opposed to CML. This is a chronic lymphocytic leukemia. Remember, CML is a chronic myeloid leukemia. So typically with CML, you're seeing, when you're looking at your peripheral smear, all the different types of myelocytes, versus in CLL, you're seeing just a whole bunch of lymphocytes and you're seeing smudge cells. CLL, couple things about it, as opposed to CML, which needs to be treated upon diagnosis. CLL only needs to be treated when it becomes symptomatic. So I probably half the people who have CLL in my clinic, I do not actually treat. I just see them every 3 to 6 months. The reason to treat people is if they have cytopenias, B symptoms, or a doubling time of the absolute lymphocyte count of less than 3 to 6 months, or bulky lymphadenopathy. Otherwise, you do not need to treat it. Even though they have cancer, you just monitor. There's no reason to treat. You're not going to change life expectancy. When you're looking to how to work up and treat CLL, you think about it. You have to subdefine it. Unlike CML, which is I guess CML, you're just finding the phases of disease. CLL comes in actually a couple of different flavors. When you're thinking about CLL, and when you're actually at the point where you need to treat someone, i.e. a rapid doubling time of a white count, and these other things I've mentioned, and don't just let a white count of 100,000 that's stable scare you. That's not necessarily something you would even need to treat with CLL. It has to be doubling, and there has to be some other symptoms or some other issues going on. Anyway, nevertheless, once you've decided that you need to treat it, in order to efficiently treat it, you need to do a couple of things. You do not need to do a bone marrow biopsy, but you do need to do FISH and PCR testing for P5317P abnormalities. The reason you need to do this is because you need to figure out if chemotherapy is an option or not for the patient. The other thing that's necessary to do for CLL, or chronic lymphocytic leukemia, is you need to know their IGVH mutational status. Knowing just those two pieces of information in a symptomatic patient, in a symptomatic patient, you can know how to treat them the most efficiently. One other thing about CLL is this can change over time, whereas this cannot. So this needs to be repeated in general whenever you're thinking about changing treatment in someone. So then looking at these, when you're looking at someone with CLL who then needs treatment, who is wild type for P53 and 17P, and they are mutated at the heavy chain loci, you can consider giving them FCR chemotherapy, which I assume you have FCR available. All right, so FCR chemotherapy in this specific subtype of patients has around a 60% 15-year disease-free survival rate. So you can offer a young patient that could tolerate FCR, who is symptomatic, who is wild type for P53, and has mutated the heavy chain loci, FCR times 6, and really giving them a chance to be functionally, if not truly, cured from their disease. Whereas normally we would talk about CLL as not being curable. In this one subset, you can actually potentially cure them with FCR. Just bouncing back up to CML for one thing too, about curability. CML, these drugs, remember, they all compete with the able tyrosine kinase. They all compete with the able ATP pocket. They do not necessarily cure the disease. You can think about discontinuing drugs in this situation when they have had a negative PCR with no detectable disease for 3 years. And those patients, you can consider actually stopping therapy for CML, though keeping in mind 60% of them will relapse. So you're not curing people typically with CML, even if you can find no evidence of disease in them, even molecularly. But if you're not able to do PCRs every 3 months, any kind of disease stoppage, treatment stoppage for CML is not reasonable. You should keep them on drug for the rest of their life. Okay, as opposed to then looking at CLL, if you can find the subtype in someone who can tolerate FCR, this is someone who you could potentially put in a durable remission for a very, very long time, if not potentially cure them. For all other patients, though, you would not offer chemotherapy because chemotherapy is inferior to the other agents in every other subtype. So anyone other than this specific subset, you would have 2 options for your first-line treatment. One would be ibrutinib, which is Bruton's tyrosine kinase inhibitor. So it's analogous to the tyrosine kinase inhibitors that are used in CML, but it hits the Bruton's tyrosine kinase, which is a tyrosine kinase that is in the B cell receptor pathway and is driven by the B cell receptor. That basically constitutively activates the B cell receptor and has it constantly firing and firing. And that's what's causing the cell proliferation. When you put someone on ibrutinib, initially their white blood cell count will go up through the roof. You can expect their white blood cell count to double, and it will then normalize over about 6 to 12 months, but not before then. During this period of time, the way that you know that the drug is working, even though their white blood cell count is going up, is they typically feel great. They have no other real major side effects. All of their lymphadenopathy typically will melt away in days. Despite that, I've actually never seen a case of tumor lysis with it. And this is an effective drug regardless of the P53 status. But just like the other tyrosine kinase inhibitors that are the ATP mimetics, or the drugs that block where ATP binds in the tyrosine kinase, they are a drug that you have to stay on forever. So unlike a diamond, more like herpes, you're on it forever and you can't get rid of it. At the same time, 90% of people will still be on drug at 5 years without side effects and still in remission, which is really quite phenomenal. Because when you look at drugs like bendamustine and Rituxan, or BR, which is one of the chemotherapy regimens that you could consider, you're typically looking around 18 to 24 month disease-free survival. So in head-to-head trials, ibrutinib has shown to be dramatically superior in overall and in disease-free survival to FCR, BR, chlorambucil, and obinutuzumab, basically all other drug combinations, other than potentially in this one subtype right here, where you had this chance of putting someone after just 6 months of therapy into remission for 15 plus years. So ibrutinib is the first line agent that we will typically consider using. Its major side effects, though, are it can cause bleeding and Afib and hypertension. The hypertension normally comes on over a period of years. The bleeding actually precludes you from using it with with any kind of blood thinners. I've actually seen it cause spontaneous subarachnoid hemorrhages. So it can actually cause significant bleeding and significant problems. And its rate of causing Afib can be up to around 15 to 20%, which you can clearly figure out that that's not a good thing, because how do you treat Afib? With blood thinners. So now, after you've caused your Afib with your ibrutinib, you have to stop your ibrutinib if you're going to put them on blood thinners. Otherwise, the risk of bleeding is very high. And their CLL comes back immediately, because remember, this does not cure the disease. There are 2 new generations of these drugs. There's acalabrutinib, which also cannot be combined with blood thinners, but it causes Afib much less frequently. Instead, it causes headaches. And then zanubrutinib, which should be potentially accessible to you guys. I don't know if you have ibrutinib, but this is made by a company called BeiGene, which is a Chinese company that sells the drugs for dramatically cheaper. So zanubrutinib might be something that you can get instead of ibrutinib or acalabrutinib. Zanubrutinib causes less Afib, less hypertension, and it does not cause bleeding, or much less bleeding. So you can actually combine zanubrutinib with blood thinners. So that is a very reasonable first-line option that may be accessible to you, because it's much less expensive. It's made out of this Chinese company called BeiGene. So that would be a very reasonable first-line option for you. Make sense? Do you have access to Xana or any of these drugs?
I should also check it.
Yeah, so
because usually oncologists do not have deal with hematology, oncohematology. So I think we should check, and I will let you know.
Yeah, because it's interesting. We don't make a distinction between oncohematology and oncology. So I do malignant hemat, because this is a lecture on leukocytosis. So it's liquid oncology. I mean, I do liquid oncology as much as I do breast cancer. So interesting. But yeah, so zanubrutinib is something that you should be able to get access to, because again, it's much less expensive. The other way to consider treating it in the first line is with Venetoclax and obinutuzumab, which is which is a CD20 monoclonal antibody. The Venetoclax works differently. It is a BCL2 inhibitor, and it's combined with a monoclonal antibody against CD20. Even though CD20 is typically dim on CLL, this is a very reasonable first-line regimen. The thing about it that makes it so attractive is you just treat people for 12 months. It is not indefinite therapy. It is much more complicated to give because Venetoclax is so effective that it can cause tumor lysis, unlike the BTKs. And you actually have to watch people and check labs on them every other day or twice a day in the beginning. And there's a 4-week ramp up to get to the full dose. When they first started studying Venetoclax, they had actually given the drugs to people on study, sent them home. Something like 3 of the first 7 of them died from tumor lysis because the drug slaughtered their CLL so effectively. So it is a very, very effective drug. The response rate for Venetoclax and obinutuzumab is around 90 to 95%, but it's time-limited therapy. And so you only treat people for 12 months. So you basically end up having conversations in the US with people who have CLL for either, I can put you on ibrutinib and it's really easy and I'll see you in a month, but you'll be on it forever. Or you're going to see a whole bunch of me. You're going to get 6 months of IV infusions with the obinutuzumab, and we're going to do tons of lab work, but there's a chance I can put you into remission and you can be off drug after just 12 months. Looking at follow-up for the Venetoclax, and when you're looking at it, they have about 3 years out data. The only people who are really relapsing are the people with a 17p, which is where P53 is, right? 17p or P53 abnormalities are the only people who are really relapsing at this point in time. Most people who are wild type for those, regardless of mutational status, are actually staying in remission 3 to 5 years out from Venetoclax, including after they have been off all drug for 3, 4, 5 years. So these are 2 very effective first-line options, and really it's a question of pay me now or pay me later. Ibrutinib, you're on it forever, but it's easy. Venetoclax kind of a pain in the butt, but you get off it after 12 months. And this is the general first-line approach for CLL. In the second-line approach, you typically would do whatever you did not do in the first line. So if and when someone fails ibrutinib, you switch them to Venetoclax. If someone relapses after Venetoclax, you switch them to ibrutinib. And doing that, and since these drugs came out probably 5, 6, 7 years ago, I have actually written for chemotherapy once in CLL, and I probably see 2 to 3 CLLs a day. Everyone goes in remission essentially, and everyone stays in remission as long as they take their drugs. The only time I've actually written for chemotherapy is with FCR, and it's in those young patients who have mutated heavy chain loci and are wild type for P53 and 17p. So really, this is a disease that, much like CML, the other chronic leukemia, we almost never use chemotherapy for anymore. It's really just treated with targeted therapy and targeted therapies only at this point in time. Make sense? Is this helpful, even though you're not?
Yes.
Don't see a lot of heme?
Very interesting. Very interesting.
Okay. So so these diseases are extremely treatable. Looking at acute myeloid leukemia, acute myeloid leukemia is clearly different than the 2 chronic leukemias because it's acute. Someone can have a normal blood count a month before, and then they will suddenly have a dramatically abnormal blood count. They'll generally present with leukocytosis. They can also present with pancytopenia. One thing just to discriminate quickly, AML from CML, if you get called by an emergency room, is AML almost never has a normal platelet count. CML usually has a normal or high platelet count. So when I get a phone call at 3 in the morning that someone has a white blood cell count of 200,000, the question is, do I get up and go to the hospital now, or would I wait till morning? If their platelet count is normal, I'm waiting till the morning. I'm going back to bed because they probably have CML. They do not have AML. AML is something that you need to react to much quicker. AML is much more nuanced and complicated of a discussion than CLL or CML. Both of the chronic leukemias have really been distilled down by tyrosine kinase inhibitors and BCL2 inhibitors into relatively easy to treat diseases. AML, on the other hand, is a relatively complicated disease. You need routine cytogenetics and you need molecular profiling to appropriately treat somebody. I remember when I lectured there at the hematology hospital, they said they did not have routine cytogenetics. Is that still true? Probably yes.
Yeah, I do not know exactly.
Okay. At a minimum, you need routine cytogenetics because you need to be able to pick up the APL patients, right? So when you're looking at these people, APL patients, they will typically have our rods, which are little purple lines within their cells. But this is back to the old 3 AML. And this is a unique disease. It's unique because it is associated by rampant DIC, where if you do not treat the people appropriately with their DIC, they will die in a matter of days. I can send you a paper on that I wrote on the management of and the acute management of AML rather than blabbering on all about it. I can just send that link to you or post that link to you right now. God. Hold on, let me just go to PubMed. And then this is the typical way that we would treat. This is the typical supportive care that we would typically do in the US. So this is just AML guidelines. That paper has way too many authors. Hold on 1 second, I will find it. Because it's of course I'm failing miserably at finding it. Give me 1 more second, because I lay out in it. It's just getting more. I will find it after the phone call, because these are all the things. So these are some of my papers, but it's me. This is me. This is it. This is in leukemia research. So this is a good paper for how to keep people from dying with AML. And it goes through all of the specific ways that we monitor people. Here's another one from me. And really, because in the beginning, what you're trying to do with AML is keep people from dying. And it's because they will quickly either die from They'll quickly either die from bleeding or from infection. And these are just some papers showing how to try to manage people in the short term to keep them from dying before you actually get them fully treated. Just looking for one other. All right, if I don't find it on this. Okay. Anyway, you get the point. There's several articles there that I just put in. And okay, anyway. So there's a couple of articles that you can reference that will tell you how to avoid early mortality in acute myeloid leukemia, how often you're supposed to check labs, et cetera, et cetera. Anyway, so if you can get the routine cytogenetics and see with the acute promyelocytic leukemia patients, they again are not treated with chemotherapy. Typically, you risk stratify them based on a white blood cell count greater than 10,000 or less than 10,000, a white blood cell count greater than 10,000. With it, you give them idarubicin or any anthracycline, really, and then you give them atra and arsenic trioxide. If they're less than 10%, you just give them arsenic and atra. Not sure if you have those available, but with the advent of these, and these were based on a paper in New England Journal of Medicine by Lococo, in the New England Journal of Medicine. You basically took APL from being the single most dangerous form of AML, and through this targeted therapy, you made it the single easiest to treat version. When you treat someone with APL with chemotherapy, their DIC typically gets worse before it gets better. They will typically actually need cryoprecipitate, platelets, and FFP and other blood transfusion support a couple of times a day. And they may not get into remission because they may just bleed to death. In contrast, when you treat them with arsenic and atra, the vast majority go into remission. In fact, there has never been a case described of APL that did not go into remission when it was appropriately dosed with arsenic and atra. It literally is 100% of people will go into remission. They are then consolidated with 4 cycles of outpatient arsenic and atra afterwards. And doing that, relapses of APL are almost completely unheard of. The only people who really don't go into remission and are cured from the disease are people who have other comorbidities that preclude you from being able to treat them, such as if they have bad renal insufficiency because arsenic is renally cleared and you cannot give it to them. But other than that, everyone should essentially be cured from APL. And again, because there's never been a case reported in the medical literature that has been resistant to arsenic and atra, versus if you give them chemotherapy, early mortality is a huge problem. So routine cytogenetics are clearly incredibly important with APL. The other major categories of AML to think about are people with complex cytogenetics. These are people who have 3 or more cytogenetic abnormalities. These people, if you give them conventional chemotherapy, which conventional chemotherapy for AML for 50 years was 7+3, which was 7 days of cytarabine and 3 days of an anthracycline, their chances of going to remission were about 10%, and they were all dead in less than a year. So the standard chemotherapy does not work for complex cytogenetics, but if you subdivide them out and find the people with complex cytogenetics, you can actually use Dacogen, which is a hypomethylating agent, with Venetoclax, which is the BCL2 inhibitor that is used in CLL. And you have, instead of in this patient population, a 10% chance of remission, you have a 70% chance of remission, and people can live for years with it and have long-term durable remissions too. So by subdividing AML out into complex cytogenetics and AML-M3, you can tailor your treatment to it and decide how to treat them with dramatically better outcomes than if you just treated everyone with chemo. Because if you treated everyone with standard chemo with complex cytogenetics, no one would really go into remission and everyone would die. If you treated it in less than a year, if you treated M3 with standard chemo, the vast majority of people would just die during induction. Other major subtypes are the core binding factors. These are the people with translocation 8, 21, and inversion 16 AML. Again, you need that standard cytogenetics for these. These are people who have very chemosensitive disease. There are actually people that you'd give standard 7+3 chemotherapy to. This is the one group in the US that we typically actually would still give them standard chemotherapy, because your cure rate for them is going to be around 70% with chemotherapy alone. So they would just need their induction chemotherapy and then 3 rounds of consolidative chemotherapy. The other thing that we add in the US though is gemtuzumab, which is an anti-CD33 monoclonal antibody that adds about a 10% benefit to overall survival. So we can get our overall survivals up to 80% with AML with these core binding factors. And then finally, there's normal cytogenetics. And then in the US, we'll send next generation sequencing or like a Foundation 1 panel. And then there's a whole list of mutations, which is available at the NCCN website. And I can give that quick reference here that you can help tailor therapy to, but a lot of times we'll just give them 7 and 3 if they're normal cytogenetics. So here's another one of my publications on acute myeloid leukemia that you can reference if you would like. They'll actually go through all the individual cytogenetics and everything else. Go through all the different cytogenetics for actually how to treat them as individuals based on that. So really with AML, it's getting them diagnosed, getting the cytogenetics back, and understanding which subtype they fall into to see if they need standard chemotherapy, if they need Venetoclax and a hypomethylating agent, or if they need arsenic and atra. And the majority of people, we will not typically be giving 7 and 3 to anymore, which is a major, major shift. Does that all make sense as a brief overview of AML?
Yes, you can continue.
Yeah. Any questions about it? Because you don't do a lot of heme malignancy, I'm just trying to give an overview of things. So does that make sense for AML in general? Yes, good. So ALL is much, much more complicated and really should be treated by people who treat ALL all the time. Treating ALL as a one-off is really, really dangerous because ALL is a very, very resistant and nuanced disease. ALL changes over time, just like AML does, just like pretty much all lymphoid cancers change over time. I mean, all heme malignancies change over time, essentially, and they become harder and harder to treat as people get older. Well, I guess that's true for AML, lymphomas, most leukemias, and ALL, because they become genetically more complicated and genetically more diverse, which makes them more resistant to chemotherapy. So ALL in kids, you can basically use polychemotherapy to cure 80–90% of them. Versus in adults, your cure rates fall down to in the 30 to 40% range because the disease becomes much more genomic and genetically complicated. I'm not really sure if you guys are, based on my conversation with the people at the heme center, I'm not really sure that you guys are treating it very much ALL. I would think that you'd be shipping ALL out because of its complexity and the number of different agents you need for it. Here is a paper going through the differences in lymphoid and myeloid diseases across the age spectrum, explaining how lymphomas and leukemias change over a patient's age. And again, that's another reference from another paper I've published. But that is a 50-minute brief overview of leukocytosis in adults, how we would think about it, how we would treat each of the diseases. And I hope that was what you were looking for with a leukocytosis talk for Leukocytosis Month.
Very interesting. I think next time you should use interactive desk.
Oh, I don't know how to use that. So
last time when you was in Uzbekistan, you always write down and draw some pictures.
Yeah, that's what I was trying to do here. And also about giving you references, and I'll give you a copy of this. I'll mail you this so you have a copy of this too, because it has all the references and everything.
I will ask the audience if there is any questions. Если у кого-то есть вопрос, вы можете задавать профессору. Если нет вопросов, мы можем закончить сегодняшнюю лекцию. So I think there is no questions, but you can send me and I will share it with our audience.
Great. I just sent it to you. And thank you for your time.
Yeah, thank you. And what about the thrombocytopenia? Do you also manage with them or no?
Yeah, all the time. So you mean just isolated thrombocytopenia?
Yeah, some hereditary thrombocytopenia.
Oh no, so hereditary thrombocytopenia, I've almost never seen in my life. Like Glasman's thrombocytopenia and stuff like that. No, those things are just incredibly rare. More than anything, we just see ITP, right? So ITP is just immune thrombocytopenic purpura. Whoops, now I'm small again. ITP, and the way that we work up ITP as an outpatient is everyone gets a bone marrow biopsy. And then we check everyone for H. pylori. Right? So, because H. pylori can, as you know, it's just gastric infection can cause ITP, and then you do a bone marrow biopsy to rule out any other disorder or any other problem. Again, assuming you can get classic cytogenetics and everything. And as soon as you've done that and you know that it's only ITP, we will typically treat people with dexamethasone, 40 milligrams Q day times 4, and 60% of people will go into remission for years. If that fails, then we will talk to them about doing a splenectomy, which also has a 60% chance of remission. If that fails, then we'll talk about rituximab, which is an anti-CD20 monoclonal antibody. Okay, which again, everything in ITP has around a 60% chance of working. And if that doesn't work, then we'll use TPO mimetics, like Nplate, and that works for everybody, but it's annoying because it's a weekly shot. So that's how we work up ITP, or work up thrombocytopenia in a outpatient setting where they're typically non-acute. In an inpatient setting, you typically don't just suddenly see ITP. Typically, if you see thrombocytopenia in an inpatient setting, you're also checking an INR, a PTT, a fibrinogen. You're looking for them to have HIT or heparin-induced thrombocytopenia. And most of the times, the thrombocytopenia you see inpatient is just multifactorial, and you really don't have to do anything about it other than transfuse. The guidelines for transfusing is you transfuse for a platelet count of 10 or lower, unless they are bleeding. If they're bleeding, it's at 50. The other thing is if they're febrile, you transfuse them at 20 instead of 10. So if you have a septic patient, you transfuse them higher than you would for a non-septic patient. But that's the general workup for it. The other things obviously you think of is, other than H. pylori bone marrow biopsies, you think about heart and liver disease. So people who drink a bunch or have hepatitis, they're going to be thrombocytopenic, but typically you're going to have other stigmata for that. You're going to know that they have liver disease. But those are the other real big things in the differential, and of course, autoimmune diseases, but those go hand in hand with ITP. So looking for things like lupus or rheumatoid arthritis, etc.
Thank you so much. I hope we can see you next time here in Uzbekistan on March. So
Yeah,
we're proceeding. You're coming here, and you are welcome anytime with your friends.
thank you. Thank you.
Okay.
Did this make sense? Is that what you were asking me for thrombocytopenia?
Yes, yes,
Yeah.
yes.
Yeah,
Thank you
so
so
that,
much.
yeah, we do. So because, again, even though I'm only a medical oncologist, we do a ton of consultative hematology and everything in the hospital. So we don't have those distinctions. Our big distinction is 18 or older. So as long as you're 18, I'll take care of almost anything you have. And if you're under 18, then it's a pediatrician. So cool. Thank you, guys.
Okay, bye-bye. See you
Bye-bye.
next time.
See you next time.